Welcome to the broadcast. We are happy to announce that all the presentations from our live symposium in June, the Complex Coronary Vascular Symposium, are now available to stream or download from your iPhone. You can also go to the cccsymposium.org site. Send us your questions to us by using the link or the page, or use the address info@structuralheartlifevalvecases.org. I also want to tell you that our next broadcast is in October 11 at 9 a.m. Now we're going to go live with Dr. Sharma and Dr. Kinney for the structural case.
Okay. Well, good morning to our viewers of structuralheartlivecases.org, and welcome from Mount Sinai, and with Dr. Pedro Moreno, the moderating today. This very interesting case. We could try to continue, identify a case with some salient points, and this is where this case will be. And of course, our team, including Dr. Kinney on my left side, Dr. Kovacic on the right side with the fellows, cath lab staff, and echo, and of course surgeon Dr. Alan Stewart just coming in. We start the case with the slide presentation, and we'll have other time for further discussion. So if we can start the slides. Okay, these are our supporters. Next, this is disclosures. Next. So basically it's a 89-year-old patient with worsening dyspnea on exertion with the class 3 and has a severe AS. Also had comorbid conditions point of view, breast CA with the lumpectomy and radiotherapy. So that really brings them to high risk with the mediastinal, hostile mediastinum. And patient has a severe aortic stenosis, which we can see by the echo. If we can show the echo now. And I did the balloon valvuloplasty actually a few months ago when patient initially presented. So Partho, you...
So this patient has got severe aortic stenosis. We are doing this procedure under conscious sedation, under transthoracic guidance. So there will be very minimal role of imaging during the procedure in this case. And you can see here, most critical part is to get a good transthoracic baseline. The baseline assessment is showing, you can see here the loop is playing with the color. The patient has a preserved LV function. There's a minimal amount of pericardial effusion. A baseline pericardial effusion to record is important, because during the procedure, if there is any change, interval change, that has to be reported. The patient has a very tight aortic valve stenosis, and you can see here on the color short axis view, I will show you right now that the patient will have, this is the short axis, simultaneously. You can see the aortic valve is extremely tight, tri-leaflet. There is no aortic regurgitation. Severe aortic stenosis, mean gradient is 48 mmHg. Preserved LV function, mild MR, and we are set for the next steps in the intervention.
Okay, go back to our slides now. Good. So next. So patient has a cath also has a non-obstructive CAD, and then with the CT angiography, good vessel size, and STS of 10 plus, so that definitely put into high risk. Anything more than 8, as we know the intermediate is between 4 to 8 or 3 to 8, and anything more than 8 puts into the high risk category. So the patient is a high risk, and of course more importantly from the radiation point of view. So actually Dr. Stewart just joined us. Maybe we'll ask him to comment in terms of radiation. Now anybody who has the mediastinal radiation in this day and age, would you just consider that patient for the TAVR if the valve is appropriate?
Yeah, I think it's one of several risk factors. Now the problem with radiation is that oftentimes we can't see the extent of radiation damage by any of our imaging. Sometimes it's very obvious on CT scan where we see a porcelain aorta, or we'll see tremendous thickening of the pericardium, but there are times when we open up the chest and we find, oh geez, everything's stuck, everything is friable from bad radiation. So I wouldn't say anyone who had radiation we would consider TAVR, but certainly it's something that would tip you over an edge when you start to get past 75, 80 years of life. I don't think a 65-year-old with radiation would be someone I'd say is inoperable, but adding all things in aggregate in this lady, she's 89, she's had breast cancer, she's had radiation, she's frail. This is not someone who's going to do well with an open aortic valve replacement. Yeah, we can get her through it, but she'll bleed a bit more. She has a higher risk of complications involving aortic bleeding, stroke, wound infection. So I think TAVR in this lady is a no-brainer. I think that this is someone we'd look at, any surgeon would look at and say, hey, if we can save this lady a sternotomy, that's the right decision.
And I think that's the important point, and the whole decision making will become a little more clear once we give the long-term data of the tire valve endurance that they perform well at 8-10 years. I think that's where it still remains. Now I'll ask a question to Dr. Keeney. Very tight valve. So question is, should we do a balloon aortic valvuloplasty in all these very tight valves before placing the tower, or should we just go ahead and minimally touch technique and try to put the valve and so? And what do you think? Because the valve is very tight, although we have done valvuloplasty about 5 months ago.
If the patient has had a recent, BAV in the last couple of months, I think ideally, no matter how tight it is, we would just go ahead and place a valve directly. But usually, I think if we have a partho or other echocardiographer in the room, they also will give us, they will tell us that how tight the valve is, and that can help us. The echo can help us to say, is it okay that we just go ahead and place a valve versus we have to do a BAV. That also with the BAV would be a 20 millimeter balloon, so that we will be able to get the valve across the native aortic valve easily.
Okay, so I think these all questions will continue to evolve, because more and more same that valvuloplasty itself could be dangerous, associated with some of the CVAs, but at the same time it's essential for your valve to get across. And then maybe by doing a preemptive balloon valvuloplasty before you put a tower, you'll decrease the post dilatation. So that's the post tower BAV is the one which to me always a concern, if by any technique you can avoid that, because that actually has been associated with additional complication besides just annulus rupture or rare cases, but the higher CV rate. So with that note, let's continue our slide presentation. This particular case, everybody agrees it's a high risk. We plan Evolut-R 29 millimeter. Next. So we have gone through the echo findings. Next. And now JK, you take over on our CT.
So in assessment of the CT, good morning everybody. In assessment of the CT, we got through the annular plane. There you can see the max minimum diameters. A fairly circular valve, not a lot of calcium in the annulus itself. Most of the calcium in this valve is up in the leaflets. Mean diameter of about 24.4 millimeters, which will be important later if we have to post-dilate. We want to go for around a 24 millimeter balloon to post-dilate this annulus. And with not much calcium and fairly circular, I think 24 is the right size here. Perimeter, 76.6 millimeters, area of 4.4. Fairly vertical annulus today with an angle of 31, so there shouldn't be any problems of the valve sitting off to one side or going in a little off angle. Next slide, please.
And actually, that's important also, the point which is coming up nowadays. We know that you have a leaflet calcium and ascending calcium, but the outflow calcium apparently is one of the bad predictor. So in a low risk trials, that if you have a significant outflow calcium below the valve, so that is patient cannot be enrolled, because those are the patients can get into trouble. And then we learning more and more about this outflow calcium, more so in the elderly age. I'm sure with the younger patient will be less, but outflow calcification is exclusion for the low risk trials. Okay, Jack.
So next, the sinus of Valsalva, reasonably generous, 30.6 millimeters mean. Sinotubular junction height again is more than adequate at 19.4. Ascending aorta is 34 millimeters across, again perfectly adequate. Coronary is nice and high today. The left man's about 16 millimeters, the right's about 19 millimeters. So anything below 12 we get worried. So clearly today, nice high coronaries. You shouldn't be worried about coronary occlusion, especially with that generous sinus of Valsalva. Next slide. You can see here for our access planning, there's some calcification at the aortoiliac bifurcation and a little bit of calcification there. You can see right over the left common femoral, over the left femoral head, which actually did dictate a role in how we took the access today. We put the main sheath in the right side, where it was free of calcification in the common femoral over the femoral head there. Next slide. You can see here's our diameters, around 6 to 7 millimeters both sides. But again, there you can see on the left, there's calcification at the left common femoral. Not a deal breaker, I think we could have done that if we had to, but obviously an easier access, safer access if we take the right. And again, there on the left of the screen, you can see at the aortoiliac bifurcation around 6 millimeters, a little bit calcified, a little bit of caution needed, but nothing to be too concerned about. So if you just go to the angiogram now, I'll just take you through the access. Show us the cines, please. So here you can see us starting the procedure. We get the small sheath set up to go up in the left. Common femoral, nice access there. Our next step is that we've gone up and over, so we've passed a 018 wire from the left side down the right iliac, down to the right popliteal vessel, and then we're now accessing the right common femoral. You can see here we've got nice access around the mid-femoral head on the right. We're now getting our annular plane set. You can see we've nicely aligned the three leaflets, the three cusps of the valve. And this will be our starting point for implantation. You can see here, minimal AI to start with. The next step is we've placed two pre-closed sutures in the right common femoral artery where we took that access, and now we're introducing this 18 French solo path sheath with the pre-closed sutures already in place. And the final step is we inflate the solo path sheath to up to 18 atmospheres. It goes in at about 12 with a nice low profile. Inflate the sheath to 18. Final step is we're checking our valve alignment, checking that the paddles are nicely seated on that valve, and we're all set and ready to go.
Okay.
Dr. Sharma.
All right, let's go. So we are ready now.
What's the ACT?
Good. So all done with the heparin. You want to go a little LO view? Let's cross slightly.
We have a
LO.
previous angiogram that shows that the arteries are fine. Is that
Yes,
correct?
yes.
That's correct.
The non-obstructive CAD, yes, absolutely.
So in discussing the value of balloon valvuloplasty here, considering it's a female, gender, and chronic atrial fibrillation, previous TIA, and the balloon might be a higher risk for increased CIA or CVA. What do you think, Dr. Sharma?
Yeah, no, I think that's it. Clearly, the issue is a very, very important one. And the whole, now, knowing that the tower is doing so good and clinically for our patients, so we're trying to see that how we can minimize the steps of a minimum trauma, so no touch technique type of situation. But then it goes back to asking our echocardiographer that what they think. So I really asked Partho earlier, and he gives a great idea, actually, and very predictable our response to the balloon valve and or advancing the valve. So he clearly felt that it's a very significant, a very tight lesion, and we may have trouble advancing the valve. So it's better we do a balloon valvuloplasty with a 20 or 22 lobe without going to very additional syringe, and that probably will decrease our post and so. So therefore, as I said earlier, to me, I think the of course, if you can avoid, that's great, and that is what we have to change. Or you're okay?
Yeah, we are okay. The
Wire is okay?
the wire is the only thing that the tip of the wire is not free. It's kind of a little entangled. So I think you might want to just clear it off. You can show the echo, and it will be very useful to notice this point.
No, just if they are showing the fluoroscopy, if you see there, the tip of the wire, what Partho is saying that is not free, you can also see there. So you got to have the tip of the wire.
So show both picture in picture with the echo and the fluoro.
So we're going with the pigtail, just to get the tip here, and now
perfect.
Now it's good.
Yes.
Yes. Good. So therefore, Pedro, we deciding that to do the valvuloplasty because of the tightness of the valve, and just at the leaflet level calcification. There's not, we saw, there's no outflow, there is no above supra valve, so it's just the leaflet. So we'll do a 20 millimeter without the syringe.
Yeah, and as you highlighted, the procedure is being associated as an independent predictor in 72,000 patients just recently published in JACC this week.
Okay, page 150
is the post-procedure BAV.
Yes.
You're absolutely correct.
Yeah. So key is that anything which will avoid the post. Good.
Go. Good. Stop pacing.
knowledge, any of the valves independent of balloon expandable or self-expandable had no difference from stroke in this procedure.
Right. Well, that's actually the issues coming up now, that we don't have, we are the only trial has been the randomized trial of the choice, but that was the SAPIEN, Edward SAPIEN and SAPIEN XT.
Get the valve.
There was numerically a little lower with the CoreValve compared to the SAPIEN, but now with the SAPIEN 3, as you saw, which is in the partner 2A and the high risk and intermediate risk SAPIEN trial of 1,000 patients, the stroke rate is very low now, 1%. So I think part of that is the delivery sheath, which has a no-touch kind of technique to going across the valve, across the arch. So part of the stroke occurs, we all know, because of the debris and scraping.
It's going to come really caudal.
So this is, now we are ready with the Evolute. So clearly the knowing that everyone has their assignment, you have to pull back, you need a wire, give the wire. Yeah, so it's not uncommon when you advance all these devices that your pigtail, which was in the good position in the aorta, it's too much magnification.
What's that little sheath, okay?
Sheath is coming out.
Yeah.
So you have to go position into the non-coronary cusp. Yeah, good.
Yeah.
No, this one. Good. Okay. You're ready?
You want to advance a little bit.
Okay, you want to take one picture now?
Okay, yeah. I'm
Okay.
going cine. Inject.
Perfect.
Okay, looks good.
Good.
So we are about
We are about releasing now. Yeah.
So we're ready to start.
Okay.
We'll go a bit slower here.
So far, so good. Anchoring.
And now we'll
Okay.
wait now. So this is the point
Anchor.
where you need to wait, because the valve is to start flaring. It is going to take its position. Now what do you think? When will you
Release.
take a picture?
No, release.
And blood
Let it
pressure is
anchor.
fine.
Okay, start pacing now. Once it's anchored. Yeah, inject.
Good.
Looking good. Take it anchored the other side. Stop
Want to
pacing.
pull back a little bit more, right?
Yep.
A little bit
So
more.
to
Yeah.
watch the pressure
Yep.
come back.
Good. Very good. Okay.
Inject.
Now, so this is the step before releasing. What do you
Okay.
think?
Looks
we can
good.
still recapture this.
Yep. At this time we can still recapture, but it looks good. So we are ready to release.
Yeah.
See
Okay.
all three cusps are away.
Good.
Nice. Now
Wire back, isn't it?
the wire back.
Good. So bring the nose cone to the center.
Come
You
down.
bring it into descending.
Okay.
Good.
Partho has lead gloves. Okay, so
You can take it
Yes.
off.
Partho, let's make sure everybody knows that. I don't want to.
So the valve was expanded. The position is good. There is mild paravalvular regurgitation.
We don't have to post.
I will take a short axis.
We started with a diastolic of 50s. We just about there.
You describe
I think
it
we will have to dilate, because there is, in a short axis view, if you can see,
at about 3. What do you think, Partho?
Yeah,
What
get
kind
it
of
ready.
car? Tiny
24.
car,
Get
no?
to 24.
Now you can see.
Pretty tiny.
at 3
Huh?
o'clock
Where's the-
position, there is paravalvular.
Okay. Show us now.
I
Okay.
guess
Sorry.
we should do an aerogram now and see.
Yeah.
No, I'm
yeah,
just
what we
showing
do
you
is,
the
We go with the echo.
Yeah, I know.
Let's see.
and then of course we're going to do our aortogram.
Now you can see here that there is a paravalvular regurgitation
At what,
happening
2 o'clock
at
position?
2 o'clock position.
Yeah.
So it is not bad, but certainly there, we can expand it if the aortic regurgitation looks more than mild on angiogram.
Okay.
And
good.
your
Let's see the-
EDP changed dramatically or not? We haven't seen it, huh?
No, we've seen with that. Okay, ready?
No, we are not there.
Yeah.
We are there already.
We're very
Okay.
aggressive about that.
Inject.
Yeah, we should dilate.
Yeah.
Yes. So same thing, the combination of both, the echo finding and our angiogram. And now we are ready. What size we have?
24.
So we have a 24 true balloon. Post dilatation with a 24 true balloon. Which is the multi-layer, very thick balloon, and the key is that here it achieve the maximum dimension when you are fully inflated. If you still need to go a little further, you have to connect it to your indiflator. Okay.
Okay, pace at 180 now.
180.
Okay, not capturing. Not at 180.
Try 170.
No. Now.
There you go.
Good. Okay.
Okay, go.
Going up. Slow, steady.
Go.
Good.
Okay, stop pacing.
Stop pacing. Now if we need to go to bigger one.
No.
You're
I
over
think
the
you
main.
expanded good.
You're over the main.
You've not
if you go
seen.
bigger.
Okay. So basically the balloon post dilatation size is according to the minimum diameter of the annulus, right?
To the mean diameter.
Mean,
So our
mean.
mean was about 24.4.
Yeah.
So we were just below the mean.
And
If
don't
we-
go more than
You
that
see,
because that's
you
where
see
you
the valve opening very well.
Yeah, valve opening well, plus also the paravalvular
Leak
regurgitation
is gone.
is gone.
Completely gone.
So I think this is a good dilatation.
See,
No
we
more
started
further
with the
dilatation.
diastolic of 50, now we are in the 60s.
Yeah. Good.
See show the hemodynamics.
Yeah, no, we'll cross now.
I'll be back. If we finish my pericardiectomy.
Yeah, no, we'll cross, then we'll show the hemodynamics.
Yeah.
No, I'm talking about
Echo-wise, I
diastolic
think it's an
pressure.
optimal
Okay.
result.
Yeah.
Okay, good.
We started with an EDP of
EDP was normal and the diastolic is the one more important here.
yeah.
Was 50 or 60 is
50,
about
50.
50, now it's about 60. So PVC is a little bit.
Okay, nice.
Good. As you see, there is no gradient. Yep.
Show the cath screen. Yeah.
Yep. Very
Nice.
good. Yep. Fluoro. Also. Good. So now our next step is we go on fluoro. No, we take the wire. 1 second. No, 1 second. So we take the pigtail out. So we need to do our final. Yeah. Good. Good. We'll leave it there.
Okay, ready?
Yep.
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 Okay, inject.
Wow.
Good.
Excellent.
Good.
No AFib.
Yeah. So this is basically is as I said, the valve itself procedure is very simplified. Excellent results. It's the more overall care of the patient pre as well as post. Really important for the TAVR program. We actually have visitors from Colombia and looking into the whole procedure. So this is now you saw the latest report that there is now 2 case reports in the literature having an ambulatory TAVI procedure. Patient went home same day. One from France, one from Canada. Same day. Second is that now the TAVR procedures are being done without cardiac backup centers. In France and other places, so they have started doing just like going through the same cycle which we went with the PCIs, that the patients could be done, appropriate patient could be done without cardiac backup. So in the labs, of course, whether it will have ever happen in America is a different story, but the key is that now procedure has become so safe. Now need for emergency, the always question comes, what is the chance of conversion to the open heart surgery during your TAVR? As you saw in the intermediate risk group, that number is 0.3%. So if we take our own data, last 400, 300 to 400 cases, none. So no case require open heart surgery. The one could happen, pericardial effusion, which is some perforation, so that you aspirate. So pericardiocentesis is done sometimes. Now with that note, while if we can go back to our slide presentation, while Dr. Kovacic is putting his, trying to get the vascular access. Next. So basically topic today, next I decided to present about the latest data because just came up on the predictors and management of coronary obstruction during TAVR. Next. So as you see, what I'm going to talk briefly and quickly on these 4 topics: the incidence of the coronary obstruction, the risk factors, the mechanism, and the outcomes. Next. So basically the incidence is various studies have shown variable, but it's about less than 1%. Next. So overall in the studies, pooled studies in 2013, 0.35, and then there was a major registry data presented. Next. Which had the large multi-center registry of 6,088 patients with the 44 who developed symptomatic coronary obstruction, making it a 0.66%. To me, that's the landmark paper for the predictors and various outcomes for the coronary obstruction after TAVR. Next. Risk factors, who develops this coronary obstruction. Next. And basically which approach you have, transfemoral, transapical or other, does not matter. It remains the same, around 0.6%. Next. But there are clear-cut factors. One is self-expanding, which is like CoreValve versus balloon-expandable. It's almost 3 times more with the balloon-expandable valve. Maybe it's part of the skirt length as well as the convexity, which we have concave at the level of the ostia in the CoreValve, that you have a less coronary obstruction. Second, if you're doing a procedure of valve-in-valve, patient has a failed bioprosthetic aortic valve, now you're putting a new valve, it's almost 2.4%, 5 to 6 times of the self-expanding valve, or you can say native valve versus 4 times with the valve-in-valve. So valve-in-valve is the one clear-cut factor of occlusion. Next. Then this is a very interesting, although it will be very miniature, but gives one clear concept. That is that we can identify these patients. There are some echocardiographic parameter, but more importantly now is the CT angio. On the CT, you can predict, you can identify the factors which are associated with coronary obstruction. One is the left main height, and second is the sinus of valsalva diameter. So what has come up? The left main height of 12 millimeter. So if you see control, that you have a higher 86% patients with the coronary obstruction as a left main of less than 12 versus 26% control. And also sinus of valsalva is 30 millimeters. So number to remember, 12 and 30, and I'll use that in my presentation a couple of times later. So now also we have seen that for the female, there is a higher incidence of obstruction of the coronaries, and there actually these numbers are even much higher for the coronary obstruction, so that you can say in the female maybe we should even go lower, not 12 millimeter, maybe 10 millimeter. So clearly the question always comes that the coronary obstruction occurs in the lower left main origin in a smaller sinus of valsalva and more common in women. Next. Now these are the various parameters. There's also one study have shown that prosthesis annulus, that if you have a oversizing more than 20%, that you have higher, the prosthesis is higher, 20% higher than the aortic annulus, that you have a higher coronary obstruction. Why? Because there is no room for the leaflet to move. They just go against the origin, because that's the most common cause of the obstruction. Next. Now this is another same left main height and aortic root, another study underscoring that aortic root, annulus as well as the left main height are the important predictor, which is again 12 and 30. Next. Now what are the mechanism? Next. And very important, it's the left main is more common than right coronary. 90% time it's a left main obstruction, 10% of the right coronary. Next. And it occurs because of displacement of the coronary leaflet over the left main origin. Because how these valve work, that original valve is basically just squeezed against, so the leaflet are sometimes vertical. If they're long leaflets or the lower left main origin, the leaflet will cover the ostium of the vessels, whether it's a right coronary or left main, because of left main origin is lower than the right. right, traditionally if you take any patient, your right coronary origin is much higher than the left main, and that's why the left main is more obstructed compared to right coronary. Next, what are the factors? High positioning, low left main ostium, narrow sinus of Valsalva, bulky leaflet calcification, and then in the patients with a valve-in-valve which are stentless. You know why? Because in the stentless bioprosthetic valve, the valve is sutured outside. Remember, in the bioprosthetic valve, suture is inside. These are the ones sutured outside, so that it's easy, the leaflets are bigger and they can displace and obstruct the vessel. So stentless bioprosthetic valves has a higher obstruction because the leaflets are sutured outside in order to get a better aortic orifice area. Next, rare cases are aortic plaque protrusion, thrombus, calcific nodules, embolization, which is rare, but can happen. It's not uncommon when you put a valve that you see little haziness at the ostium. It could be just because of the thrombus or some plaque protrusion. But majority of the time when you see it, it's closed because of the leaflet. Next. The outcomes, clearly next. Basically that once it occurs, the PCI, of course, you had to do it. The PCI in this study, it was attempted in 75% of cases and successful in 82. 18% of patients you could not get. Knowing that 90% was left main, you could not wire it because the left main is totally obstructed. People have done that. Once you know exactly where it is, they put a guide catheter and take the back end of the guide wire, which is stiff, and puncture the tissue valve. I mean, the key is that you need to go through your prosthetic valve and then, of course, go through the coronary for the aortic, native aortic leaflet. They're taking the back end of the guide wire and make a puncture. If you are unsuccessful, next is associated with very high mortality, which is 100%, which we know. And of course, whether you do PCI or CABG, most of the patients get PCI and not the CABG, but that is what in some cases have been done. Next. Now, once it is done, is associated with still high mortality overall. But clearly, once you are successful, it is less, but overall was 40% next. And at 1 year, it was okay. So after the first initial mortality, then your subsequent mortality was not much different, only 3-4 points higher. Next. So now the question is then, how do you left main coronary obstruction during the planned or preemptive strategy? And that's where it is. We understood this is my high risk case. What can we do? Next. So now the latest paper just came out last month was the TAVR left main registry. 204 patients with a TAVR and left main. 176 had pre-TAVR, 9 had a post-TAVR, and 19 were unplanned. So you see it, majority of the patients get the TAVR, the left main PCI before the TAVR. And that is what we are also teaching everyone, and we are doing it. That if you have a CAD, you take care of it before you do the TAVR. Because otherwise, doing a TAVR intervention is more difficult once you have the valve in place. So idea is that if you have significant CAD, you do a PCI first before patient going for TAVR, or some of these cases could go for CABG and aortic valve replacement. Next. So this is where it's the graph of the cases 204. Next. Now also what they learn that whether you have a TAVR plus and they have the matched from the registry that you have a TAVR only. So left main PCI and TAVR had a similar outcome at 1 year. Identical outcome at 1 year of about 92%. So very simple that left main PCI with TAVR and those are TAVR only have an equal outcome in the matched population. So now clearly the issues are that anatomic consideration, hemodynamic compromise during intervention, timing of the left main PCI, osteal or non-osteal, planned or unplanned. So clearly the issue comes that you should have a planned PCI in this case if there is a disease. If left main disease, plan the PCI beforehand. Whether it's osteal, non-osteal was no difference. And of the timing of the left main PCI, people believe that should you do it few months before or few months after. Next. And actually have shown that whether you have protected left main or unprotected, there was similar 1 year mortality, or you do it within 3 months or more than 3 months of your TAVR, identical. Clearly, there is you can make it a point that in some cases you want to do both left main PCI and TAVR at the same time to avoid the issue about the anticoagulation and so. But at the same time, we know the PCI has a very low complication. TAVR may still have 1 or 2% mortality. So we try to avoid them. So we do a left main PCI first, discharge the patient, and then 5-6 weeks later, then do the TAVR. Next. So that's now the 1 year mortality, clearly that if you have a planned versus unplanned, these are the patients who have disease left main. Your unplanned PCI needing emergency PCI during TAVR will have a higher 1 year mortality, obviously, so there is no brainer on that. Clearly, so that if you have a disease, take care of it before you do a TAVR procedure or peri-TAVR. Next. Now, very important, and this is actually interesting, which we, technique really propagated by Raj Makkar, and we learned because of one of our case 2 years ago we did in live symposium, and we have done it, that if you know that you could have coronary obstruction, particularly left main, identify based on the grounds which we have talked, less than 12 millimeter height of the left main, sinus of Valsalva less than 30 millimeter. So you can use the preemptive technique. And what is the preemptive technique? Next, it basically was that 25 out of the 623 patients on the TAVI at their institution, they have a preemptive left main protection technique. That means you advance the deflated stent into the left side at the time of TAVR. If your obstruction occur of the left main, you pull it back and deploy at the ostium. So although it was needed in only 5 cases of the 25, these were the high risk patients because they have a low left main origin, they have a smaller sinus of Valsalva, they are valve in valve, but required in 1 to 5 of the cases, but all those 5 cases did very well, and that is the key. So when you have occurred in 5 of the 25, all were deployed successfully with emergency left main stenting. Next. And this basically is, you can see at 12 o'clock position, whether it's a CoreValve or the Balloon-Expandable, that you have the stent placed. Next. And so next, so basically these are the same factors. So we had a case about 2 years ago in our CCC live case symposium. Next. So we asked that how we do it. So now this is actually, can we play the video? Yeah, good. See the left main height? Keep playing. This case, left main height was 9 millimeter. From the annulus. See that left main height very short. Next. So this was our first case. We can go to the next view now. Okay. I know there are the issues having a problem with the loop. So we go to the next. Yeah. So there was some no significant disease of the left main. Next, these are the cases we are talking about. If there is a left main disease, you put a stent in the left main first, wait 5 weeks, 6 weeks, and then do the TAVR procedure. Next. So what we have done, you see that at 1 o'clock position, there is a 4O 12 millimeter stent deflated in the LAD. Now we are doing a balloon valvuloplasty, and people actually have seen, also predicted that if you do a fully inflated balloon and you do a little aortogram, it will tell you whether there is a likelihood of the leaflet protrusion. See here, there is enough gap. So in this case, although we since then we had done 3 more cases, this is our total 4 cases we had done, this high risk. Not every case we had done the balloon valvuloplasty and the dye, but you can always see when you do a balloon valvuloplasty, if there is enough gap, you know that even leaflet will move, it's not going to obstruct. But key is that you have a guide catheter, you have the wire, and then there is a deflated stent. Next. So this is the case. Now we are deploying the Sapien XT. Now there is a whole question comes, Sapien XT versus Sapien 3, knowing that the height of the Sapien XT is smaller than the Sapien 3. So many people prefer XT. For this purpose, same thing when you are doing a valve in valve, high chance of coronary occlusion, so Sapien XT may be preferred over the Sapien 3, but at the same time we know the CoreValve has a lower the coronary obstruction. Next. So now the deployment, now see that we are fully deployed, the deflated stent is still there. Next. So now you take it out and take a picture. Looks good, left main is fine. Now you can remove your deflated stent, nothing need to be done. But if it would have obstructed, you would have bring it back to the ostium and deploy it. So this is the technique. Next. So therefore, I sum it up, the suggested flow chart for the preemptive left main protection based on the pre-TAVI evaluation. If you have significant left main disease, put a stent. Done. If you have high anatomic features or valve in valve, so basically low left main height, less than 12 millimeter. All those, I would say the data actually from surgical cardiothoracic study, they are saying for women should be 9 millimeter. and shallow sinus of Valsalva less than 30 millimeter, severe calcification, high of the native leaflet and extreme oversizing, you do a preemptive left main protection. Now we actually cases which we have done, none of them we require putting a deploy the stent, but we have used that technique. And the valve-in-valve, of course, the high-risk bioprosthesis, which is the stentless valves of the trifecta, stentless valves, and the two others, mitroflow and trifecta, because of the large valve leaflet, are associated with higher valve-in-valve coronary when you do a TAVR with a coronary obstruction. With that note, next, we just sum it up. Our take-home message that coronary obstruction, mainly left main occlusion, is a rare complication of TAVR, but is potentially catastrophic and associated with high mortality. It can be predicted by some CT parameters and is higher with valve-in-valve TAVR procedure. Next. The patients who have high-risk anatomy for left main occlusion without left main lesion can be managed safely. Key is, if you have left main lesion, put a stent first. But not there, then you do without left main lesion can be managed safely by preemptive undeployed stent in the left coronary system at the time of TAVR procedure. And then, of course, if it gets obstructed, you then deploy it. Patients with left main disease and severe AS are best managed by left main PCI, then TAVR at 1 to 3 months post with excellent 1-year outcomes. So with that note, I just quickly go the questions, and I think we are done with the vascular. So we go 3 questions here. Following are the true statement about coronary obstruction during TAVR except. That means which one is wrong? It occurs in less than 1% of cases. It is more common with valve-in-valve procedure. Both RC and left main can equally be affected. It is associated with 30 to 45% in-hospital mortality. So answer is, next, clearly both RC because it's predominantly left main. Next, question number 2. Following statements are true about the risk factor for coronary obstruction during TAVR, except low sinus of Valsalva, short left main height, male gender, and extreme oversizing with high valve to annulus ratio. Answer is C. The third question. We go to next question. That is, left main disease treatment or protection during TAVR can be best provided by the following technique. Perform left main PCI at the time of TAVR, perform left main PCI after TAVR, deploy the left main stent prophylactically in high-risk patient, or preemptive technique of deflated stent in the left coronary during TAVR in high-risk patient for left main occlusion. I'm sure it is a clear-cut answer. Answer is D. Good. Now, okay, now JK has finished the groin and tell us where we are.
Just show the angios, please. Great. So we're just getting the sheath out. As you remember, the large sheath was in the right side, the right common femoral. What we've done here is we've withdrawn the solopath sheath just to about the bifurcation of the external-internal iliac. We have now a long sheath, a 40-centimeter sheath up the left side, which is positioned just inside the left common iliac there. We're taking a first DSA run. You remember there was some calcification at the aorto-iliac bifurcation. Important to see we haven't dissected or perforated anything worse, but obviously no problems here with this initial shot. We then retract the sheath further, so the sheath is now in the external iliac. We've actually crossed up and over from the left side with that long sheath, so we're now actually taking a DSA run with the left sheath positioned at the bifurcation of the external-internal iliacs and about to remove the sheath. The next shot, we've actually pulled the sheath out. I've deployed the per-closed sutures, and here you can actually see the first shot with the sheath out, per-closed sutures deployed. You can actually see a little bit of extravasation coming out the wire tract. So at this point we have an antegrade and a retrograde wire. We've got great control of the situation, a little bit of leakage out the wire that's actually getting externalized there, just out the tract. So we then took a 7040 balloon, which you can, a great teaching point I wanted to show you here. So what we'd actually done before the case is we actually had that 018 wire down the right leg. And when we actually went to advance the balloon to tamponade this, it was quite obvious that we actually had the balloon, the 018 wire hooked up under the pre-closed sutures. So this was something that when we started doing this, I used to fear quite a lot, is you can see us trying to gently advance the balloon. It's not going, it's actually stuck at the pre-closed suture level. This used to worry me greatly. But it's a very easy thing to just bring the balloon back an inch or so, bring the wire back, it comes back very easily, and then just re-advance the wire. So what we've done here is I just pulled the balloon back, pulled the wire back and re-advanced the wire. I'm checking I've got the wire nicely in the lumen, no dissection. and we just go forward with the balloon and dilate. That took about 1 minute. Used to concern me greatly, but this happens, I don't know, once every second month, a few times a year. It's never been a problem. So we then just ballooned, DSA, final shot, and I think we've got great hemostasis, a great result. That extravasation is fixed, vessels wide open, and we're done. The left side, there was a little calcification at that left common femoral. Left will just be a manual hold. It's only a 6 French sheath.
Okay, good. Anu, from your side, and last point.
Oh.
Yeah.
Nothing. I think I could say that with the left main occlusion, how catastrophe it could be, that you should be at least prepared if actually happens, and the case shown that that you have to have a stent anywhere in the LAD or left main probably is a great way actually to predict and prevent any kind of a left main occlusion, if at all there is a case that you can predict.
Yep. Okay, for Pedro, from our side, we are done, and announcement for the next the webcast in October.
Yeah, I think we have seen a fantastic case today, excellent planning, high-risk patient, perfect deployment, perfect care of the peripheral vascular issues. And now, remember, October 11 at 9 a.m. we'll be here for you. Thank you so much.